Welcome to the deep dive.
Okay, let's unpack this topic today. Wide-awake surgical management of hand fractures. You probably know it as WALANT. This deep dive is really tailored for you plastic surgery residents and attendings. We're focusing on the practical stuff, the clinical applications, real-world surgical decision-making, and those, invaluable pearls for patient management and, yes, even board prep. Our discussion is based on a really interesting article from Plastic and Reconstructive Surgery. It's titled Wide Awake Surgical Management of Hand Fractures, Technical Pearls and Advanced Rehabilitation.
Yeah, and what's fascinating here, what really resonates for me, is how this concept, patients being awake during hand surgery, it's not just some minor tweak. It's fundamentally reshaping hand surgery. It kind of challenges decades of, ingrained practice. It's transforming not just how we operate, but really why we even choose an OR for certain cases sometimes. It's quite a profound paradigm shift benefiting both surgeons and patients. That's a powerful way to put it. So it's not just a technique, it's a whole new way of thinking, isn't it? Let's get right into the immediate advantages of WALANT then, because these really highlight that shift you mentioned. I mean, for ages, the idea of using epinephrine in fingers was basically forbidden, right? A strict contraindication. But now we've got solid evidence showing it's safe, it's effective, and the benefits that unlocks are, well, pretty significant.
Absolutely.
Take cost, for instance.
Yeah.
Economic impact is huge. Surgical cases done with WALANT, say in an office setting, they consistently cost, what, a quarter or even less than the same thing in a traditional OR with sedation or general anesthesia. That's a massive financial win for the system and for patients, too.
It really is. And beyond the numbers, you touched on something important, the patient experience.
Yeah, tell us more about that. What about the less tangible benefits, especially for patients maybe anxious about general anesthesia?
Well, that's where WALANT truly shines, I think. The satisfaction rates are exceptionally high. Think about this. 2/3 of patients say it's less uncomfortable than a dental procedure, minimal anxiety during the operation, and over 90% say they definitely choose WALANT again.
Wow, over 90%.
Yeah. And think about what they avoid. No nausea, no vomiting from general anesthesia, no fasting needed beforehand. Many can drive themselves home afterwards. No need for pre-op medical tests or clearances in many cases. Plus, a lot of patients really appreciate being active participants. They understand what's happening. It feels less like something being done to them and more like they're involved. It's empowering.
That makes sense.
And if we connect this to surgical practice, the clinical advantages for hand fracture fixation are, well, they're kind of a game changer, especially for making decisions during surgery.
How so?
Imagine this. Your patient's wide awake. You can assess, you can actually challenge your fixation stability right there, intraoperatively. You guide them through active motion, maybe under fluoro, and you get immediate dynamic feedback on how stable that reduction really is. That insight is, frankly, invaluable.
That real-time feedback sounds incredible for surgical confidence.
Yeah.
Are there specific times where that really prevents a post-op problem?
Oh, definitely. Say you have a concomitant injury, like a flexor tendon laceration repair. You can check that repair right then and there for any gapping or catching while the patient actively moves their finger. This immediate check of both the fracture and the tendon lets you tailor the post-op plan. You might shorten immobilization, push for earlier rehab, which means less stiffness, quicker return to function. And let's not forget the practical side. The epinephrine gives you great hemostasis, better visibility, less bleeding. It just makes the surgery smoother.
Okay, that immediate feedback loop is clearly powerful. But like any tool, you need to know when to use it and who it's right for. So this brings us to patient selection, super critical. For residents prepping for boards or attendings refining protocols, what are the clear indications for WALANT?
Absolutely fundamental. Okay, indications. You need a cooperative patient. You need to be able to get effective local anesthesia and, critically, no contraindications to using epinephrine. It's ideal for most metacarpal and phalangeal fractures, dislocations too, especially good if there are associated tendon lacerations. And it's a fantastic option for patients with medical issues, comorbidities that make general anesthesia risky. We can avoid those systemic risks entirely.
Okay, those are the green lights. What about the red flags, the absolute no-goes, and maybe the relative ones where you need to pause and think?
Good question. Absolute contraindications. Any history of vascular injury to that digit. Underlying vascular disorders, think Raynaud's, maybe Berger's disease, allergies to the local anesthetic, obviously, and extreme anxiety that you feel can't be managed. Also, really extensive injuries, major bone and soft tissue damage needing big debridement local just won't cut it there.
Makes sense.
Then you have relative contraindications. Moderate anxiety, sometimes manageable with a small oral dose of something like diazepam, maybe a 5 milligram before the injection. Complex injuries like segmental bone loss might be relative. Patient positioning issues, severe shoulder pain, bad back pain, making it hard to lie flat could be relative. Although sometimes you can adapt, maybe do the surgery with the patient sitting up if your team's okay with that. And obviously, very young kids who just can't tolerate an injection or stay still, they're generally not candidates.
You mentioned extreme anxiety as an absolute contraindication.
Hmm.
But what if someone seems okay beforehand, but then starts to panic mid-procedure? How do you handle that wide awake? And maybe more importantly, how do you prevent it with good communication?
That's a really practical point, and it underlines why patient prep is such a key resident pearl. Setting expectations is everything. First, clear communication. Use simple terms. Instead of prep the hand, say, well, wash your hand with surgical soap. Instead of reduce the bones, maybe we'll set the bones back into place. Demystify it. Build that trust.
Okay.
Second, anticipate the stress points. Warn them about sounds, like the drill. Compare it to a dental drill, noisy but shouldn't be painful, something familiar. Explain they'll feel pressure, movement, but not sharp pain. Reassure them that feeling normal sensation elsewhere doesn't mean the block isn't working where it needs to.
Right. Manage those expectations.
Third, involve them. Show them the x-rays, explain the injury, be upfront if it might be a longer or trickier case. And here's a really useful clinical pearl. Coach them on what they'll need to do, like making a fist, extending fingers. You can even practice this after the anesthetic works, when the fracture pain is gone, but before you drape. It empowers them, gives them a sense of control, and really cuts down on anxiety during the case.
That's smart, like a little rehearsal. It must still be a mental shift for surgeons used to a totally passive patient, though. What's the biggest internal hurdle for surgeons adopting this?
It definitely takes a different mindset, yeah. Learning to communicate constantly, explain everything, that's a skill you develop. Maybe the biggest challenge is letting go of some of that traditional control you have in a fully sedated setting and really seeing the patient as an active partner. But it makes you a better communicator, I think, and ultimately more adaptable.
Okay, so let's shift to the technical side, the anesthetic edge. What are the key things for getting a successful wide-awake block?
Right, the pharmacology. Standard is 1% lidocaine with 1.100 epinephrine. It's widely used, proven safe. Max dose usually quoted around 7 mg per kilogram, conservatively. And you mentioned patient comfort. Minimizing that initial sting is huge for trust, right? Lidocaine's acidic, average pH around 4.2, so you buffer it. Add 1 cc of 8.4% sodium bicarbonate to 10 cc of the lidocaine Epimix. That 1 to 10 ratio really helps reduce the burning sensation.
It makes a big difference.
Volume-wise, you're looking at maybe 10 to 20 cc of that buffered solution, depending on where you're working phalanx versus metacarpal, for example. Placement is key. You do a regional block proximal to the site. But the critical part for WALANT is infiltrating all around the surgical site. You want that tumescence, that swelling, and the vasoconstriction from the epi for your bloodless field. And for fracture specifically, the periosteal block is vital. Inject right next to the bone, just proximal to the fracture. And this is important. Get it down to the far cortex too, especially if you're planning by cortical pins. Prevents pain during pinning. This ties into that hole-in-one anesthesia idea, right? Each injection goes through tissue that's already getting numb from the previous one. So ideally, just one initial skin poke.
Exactly. Minimizes discomfort significantly, and that leads nicely into avoiding failed blocks, which is crucial, especially for residents. The article points out 3 common reasons for failure. First, simply not enough volume. Don't be timid with the infiltration. That tumescence is your friend. Second, missing spots. You have to inject everywhere you might dissect and put a pin. Think comprehensively. And third, not waiting long enough between injection and starting surgery.
The timing aspect.
Yes, critical for OR efficiency too. Lidocaine starts working fast, maybe 3 minutes or so. But the epinephrine for that maximum vasoconstriction, that bloodless field, it takes about 26 minutes on average. So you need to build in a 20 to 30 minute delay. A smooth workflow looks like this. Discuss, consent, inject. Then, while that time passes, the team sets up the room, preps the hand, drapes, positions. By the time you're ready to make skin, the field is perfect. You can even optimize it further in busy practices by prepping the next patient while the current one's anesthetic sets up.
That's some slick OR choreography. So the wait time is up, the patient's comfortable and awake. How does this wide-awake state actually change your surgical fixation approach? Does it influence your technique choices?
It does, absolutely. Though you have to be mindful the tumescence can sometimes obscure bony landmarks a bit, so meticulous pre-op planning and good fluoro use are even more important. For most phalangeal and metacarpal fractures, if the pattern allows, close reduction and percutaneous pinning with K-wires is often preferred. It's less invasive, less soft tissue disruption, preserves the fracture biology better, and the pins come out easily later. Just remember, K-wires don't give compression. If you need compression for that fracture, you're looking at screws or a plate and screw construct instead.
Okay, and I imagine that real-time feedback is especially useful with percutaneous pinning. Can you walk us through some specific fixation pearls for residents or maybe attendings refining their WALANT skills?
Sure. Let's take metacarpal fractures, neck or shaft. Stabilize with 2 longitudinal K-wires. Pass them retrograde from the collateral recesses at the metacarpal head. Why there? Because that insertion site allows for early active motion without the extensor tendon getting snagged. Here's a neat trick. Use a 16 or 18 gauge IV needle cannula as a pin guide. Helps get the angle right, helps you aim through the narrow part, the isthmus. For border metacarpals, index or small finger, you need rotational stability. So add transverse pins across to the adjacent stable metacarpal.
Got it.
Thumb-based fractures like Bennett or Rolando patterns reduce with traction, pronation, palmar abduction, then typically 1 K-wire retrograde from the thumb metacarpal into the trapezium, plus a second K-wire transversely from the thumb metacarpal to the index metacarpal again for rotation control.
Okay, what about phalanges?
Proximal and middle phalanx fractures. If it's transverse, cross pins inserted at the collateral recess usually work well. If it's spiral or oblique, use transverse pins, but place them at or maybe even dorsal to the mid-axial line. You've got to stay away from the neurovascular bundles. And a really critical pearl for these oblique spiral ones, use at least 3 pins. 2 pins often isn't enough, and you risk losing the reduction later.
3 pins minimum. Good tip.
Yeah, proximal phalanx base fractures. Treat those with pins around the joint, periarticular or sometimes transarticular through the MP joint, holding it flexed. Make sure the pins exit near the proximal phalanx neck, not down in the web space where they'll irritate the skin. And lastly, distal phalanx fractures, those bony mallet injuries. Extension block pinning is the way to go. 1 pin levers the fragment down away from the middle phalanx. A second longitudinal K-wire stabilizes the DIP joint straight.
That's a great detailed walkthrough. Lots of specific tips there. Now, you mentioned this earlier, but let's circle back to what many call the holy grail of WALANT, confirming your work in real time. Paint a picture for us. What does that look like in practice? Why is it such a game changer?
Right. This is the core advantage, really. Once you've placed your fixation, your pins, or whatever you use, you gently take the patient's fingers through some passive motion. Then, the crucial part, you ask the patient to actively move their fingers, all while you're watching under live fluoroscopy. The goal isn't necessarily full range of motion right then, but repeated confirmation that the fracture is stable through movement, and also checking that the pins aren't catching skin or tethering tendons. You check rotation too, have them make a gentle fist, then extend, does it look right? No weird angulation or rotation compared to the other fingers. This gives you immediate, objective feedback, and it's your decision point. If it looks unstable on active motion under fluoro, you can put in more fixation right then and there, or you make the informed call to adjust the post-op plan, maybe immobilize instead of starting early motion because you know it's borderline.
Mm-hmm.
That immediate feedback loop changes everything for rehab.
Exactly. So, okay, surgery's done, fracture stable, you've confirmed it actively. What's the next step for the patient? Let's talk rehab pearls.
Right. Because you've confirmed stability intraoperatively, these wide-awake patients are perfect candidates for early motion rehab. The goal is minimizing stiffness. They'll still be protected, usually with a custom functional orthosis immobilizing the joints just above and below the fracture. We often use something like a modified St. John protocol. Key ideas are: get the patient off pain meds quickly, use pain as their guide if it hurts too much, back off the motion. This helps prevent losing reduction or irritating the hardware, and allow gradually increasing motion. A neat psychological boost is that patients remember actively moving their hand during surgery. That becomes a concrete goal for them in therapy.
That memory must be quite motivating. What's the typical timeline? K-wire removal, getting back to activities.
Generally, K-wires can often come out around 21 to 28 days. Even if the X-ray still shows a bit of fracture line, if there's no pain, no significant bone loss, or bad comminution, they can usually come out. The orthosis is typically ditched by 4 to 6 weeks. Then it's a gradual return to normal activities. We usually advise avoiding high-impact stuff for about 3 months, though.
That progressive approach sounds very logical, but we always have to consider the downsides, potential problems. What about complications? Critical points for board prep and just safe practice.
Yes, always have to discuss complications. Crucial for safety and exams. Let's start with epinephrine-related issues. Digital necrosis, while rare, is devastating. Big studies show epi was safe in the digits, but there have been, I think, 4 reported cases since 2012 where necrosis occurred, and importantly, phentolamine rescue wasn't used in any of them.
Phentolamine rescue. Key point.
Absolutely. It underscores 2 things. First, remember those absolute contraindications. Vascular disease like Raynaud's means no epinephrine, period. Second, and this is an essential pearl, if you use epinephrine in the hand or fingers, you must always have phentolamine available and know how to use it for rescue. That's 1 milligram diluted in 5 cc's of saline, infiltrated around the area if you see signs of vascular compromise.
Yeah.
And a technical tip, inject the epimix into the subcutaneous fat, not directly into the flexor tendon sheath.
Okay. And other complications, fracture-related ones.
Yeah, the usual suspects. Loss of reduction, but hopefully less common because of that intraoperative active motion check we talked about. Pin migration can happen. And pin tract infections, they occur in maybe 6 to 9% of cases. Usually just needs oral antibiotics. Less than 2% might need a surgical cleanout.
So bringing it all together then, what does the overall evidence show? What are the outcomes like with this wide-awake approach?
Well, because it's relatively newer and widespread use for fractures, a lot of the evidence comes from case series and expert opinion rather than large randomized trials comparing it directly to GA for everything. But the studies we do have show consistently good outcomes for K-wire fixation of hand fractures done this way, especially regarding range of motion recovery. And patients report very low pain scores during the actual surgery, usually like 1.5 or less on a 10-point scale. That's pretty remarkable. Specific studies show good motion return for metacarpal and phalangeal fractures. Although it's fair to note for proximal phalanx base fractures specifically, some studies found about half the patients had some residual PIP joint stiffness, maybe around 27 degrees loss on average.
Okay. So wrapping this up, what's the bottom line here? What does this all mean for you listening in, whether you're a resident starting out or intending, looking to refine your practice? WALANT offers, well, really immense value, doesn't it? From cost savings and much higher patient satisfaction to those unique intraoperative insights that let you make better decisions and tailor rehab. It really is a complete shift.
I agree. For plastic surgery residents and attendings, look, WALANT is much more than just anesthesia. It's a whole philosophy. It's a comprehensive approach that can genuinely improve patient care, make your practice more efficient, and honestly, boost your confidence as a surgeon. It empowers you to assess, adapt, optimize, all in real time.
So here's something to think about. Consider how embracing this dynamic, patient-involved approach could maybe streamline your practice, improve your outcomes, and fundamentally reshape the surgical experience, not just for your patients, but for you too. What parts of your current practice might benefit the most from adopting this wide-awake perspective?